Getting a medical device into a precise vascular target requires sliding a series of tubes and wires over one another. This is the coaxial system. If you examine the packaging for any standard angiographic catheter, you will find three distinct measurements: a French size, a length in centimeters, and an inner diameter measured in inches. This animation illustrates a dimensional paradox that immediately confuses trainees. You will frequently be instructed to place a 4 French catheter inside a 4 French entry sheath. If both objects possess identical diameters, they should physically fail to fit together. Misinterpreting these numbers is not a minor clerical error. Forcing mismatched components together strips the lining of arteries, causes vessel dissection, or results in total procedural failure before you even reach the target anatomy. Rote memorization of tool lists will not prevent these errors. Safely executing an angiogram requires deriving the underlying physical logic behind dimensional mapping, whole flow dynamics, and tip geometry. The logic begins at the foundational layer, the patient's entry point, which is secured by the vascular sheath. This diagram shows a cross-section of a vascular sheath. Sheaths are defined exclusively by their internal capacity. This interior void is measured using the French scale. A 4 French sheath guarantees exactly 4 French of empty space inside the tube. The next layer of the coaxial system is the catheter, which must smoothly travel through that precise empty space. Catheter sizing reverses the rule. A catheter is defined by its exterior footprint. Its outer diameter is what gets measured on the French scale. The physical paradox is resolved. A 4 French sheath accommodates a 4 French catheter because the sheath's internal roid perfectly matches the catheter's external wall. The final, deepest component of the access system is the guide wire, which travels inside the catheter. Here, the measurement system abruptly changes. Catheter internal diameters and guide wire external diameters pair strictly in fractions of an inch. A catheter with an inner diameter of 0.035 inches will perfectly accommodate a maximum wire size of 0.035 inches. The remaining number on the packaging simply dictates the total working length of the catheter in centimeters. Standard options range from 45 to 125 centimeters, depending on how far the target vessel is from the entry site. The completed coaxial system relies on 3 disparate measurement rules. Mechanical compatibility is dictated by the sheath's inner diameter, the catheter's outer diameter, and the exact pairing of inches between the catheter's void and the guide wire. Once the sizing is correct at the entry point, the focus shifts to the distal tip of the catheter operating deep inside the vascular system. Catheters are divided into 2 primary structural classes: non-selective flush catheters designed for large main vessels, and selective catheters designed to navigate into smaller branch vessels. The pigtail catheter is the standard non-selective tool for high-volume injections into large vessels like the aorta. It features a curled distal end and is manufactured with both a terminal end hole and multiple lateral side holes. This simulation shows why those side holes are necessary. When injecting high volumes of contrast fluid, the side holes diffuse the extreme pressure laterally, preventing a single violent forward jet. Simultaneously, as the guide wire is retracted, the tip curls into its namesake pigtail shape. This blunt profile bounces off the vascular walls, preventing the high-pressure system from accidentally dropping into and destroying a small, delicate perpendicular branch. Selective catheters serve a different function. Their tips are angled to intentionally hook into those branch vessels. The most basic selective model features an end hole only, with no lateral side ports. Because it lacks side ports to diffuse pressure, an end hole only catheter is strictly limited to low-pressure hand injections. Subjecting it to a high-pressure mechanical pump is dangerous. Pumping a rapid bolus of fluid through a single exit point creates intense forward velocity. According to basic physics, this forward jet generates an equal and opposite reaction, causing violent recoil. The tip will whip backward, displacing the catheter and potentially tearing the vessel wall. Despite this severe recoil risk, end-hole-only models are strictly mandated for embolotherapy, where physicians carefully inject physical materials to block blood vessels. To solve the recoil problem for diagnostic imaging, manufacturers created a hybrid, the side plus end hole selective catheter. This hybrid allows physicians to safely use rapid pump injections in branch vessels like the superior mesenteric artery, or SMA. The side holes diffuse the pressure, keeping the catheter perfectly stable during the run. However, this diagram shows the catastrophic failure that occurs if you use this hybrid tool for embolotherapy. The physical embolic coils or particles will jam into the side ports. They will leak out sideways, drifting into non-targeted vessels and destroying healthy tissue. The injection material dictates the physical tool. Mismatching the hole configuration causes either violent recoil dissection or disastrous non-targeted embolization. Beyond fluid dynamics, selective catheters present a physical steering challenge. Navigating from a main artery into a specific branch requires matching the tool to the patient's anatomy. Selecting the correct catheter tip is an exercise in applied geometry. Branch vessels split off the main artery at predictable angles, which fall into 3 distinct mathematical categories. This schematic shows the first category, acute takeoff angles. For vessels branching at less than 60 degrees, such as the aortic arch vessels, physicians select an angled tip catheter. The tool's manufactured angle maps perfectly onto the upward branch vector. The second category covers standard angles between 60 and 120 degrees, typical of the renal arteries. These require a standard curved catheter to cleanly align with the lateral entry path. The most extreme geometric challenge is the obtuse angle. Vessels like the celiac or the inferior mesenteric artery branch off at angles greater than 120 degrees, pointing sharply downward and away from the direction of blood flow. These targets require a recurve catheter, such as the Simmons or the renal double curve. These tools are unique because they feature a primary curve going in one direction, immediately followed by a secondary curve pointing the exact opposite way. Engaging an obtuse vessel demands a counterintuitive physical maneuver. You cannot push the catheter into the target. Instead, you advance the catheter past the branch origin to form its recurved shape in the main vessel. Then you pull the entire system backward, causing the primary curve to drop down and hook into the obtuse angle. Cannulating difficult anatomy relies entirely on mathematics. You thoughtfully evaluate the geometric origin of the target and select the exact manufactured shape to solve it. With the catheter securely in the target vessel, the final procedural step is determining the maximum safe rate of fluid injection and maintaining a clean system. Maximum flow rates are mathematically capped by the internal diameter and hole configuration of the catheter. A dependable baseline rule is that each French size allows for approximately 8 milliliters of flow per second. Applying this heuristic yields specific physical limits. A 3 French catheter maxes out at roughly 8 milliliters per second. A 4 French handles 16. A 5 French scales up to 24 milliliters per second. The total volume of that injection is then adjusted based on the specific capacity of the distal arterial bed. A large abdominal aorta requires heavily increased volume compared to a smaller thoracic target. Between these injections, the coaxial lines must be cleared of internal clotting. For procedures below the clavicles, the standard protocol is the single flush, aspirating until 1 drop of blood enters the saline syringe, tilting to a 45-degree angle and pushing the saline forward. Procedures above the clavicles, like cerebral angiograms, require a rigid double flush protocol. Even a microscopic air bubble or thrombus in the brain causes a stroke. The operator aspirates until blood clears the catheter, but then that syringe is discarded entirely. A brand new, sterile, air-free saline syringe is attached for the actual flush. Strict adherence to flow equations prevents the system from rupturing under pressure, while double flush protocols guarantee that 0 lethal artifacts are introduced into the neurovasculature. We can now synthesize these isolated rules by executing a high-flow angiogram of the superior mesenteric artery. Reaching the obtuse angle of the SMA requires a mathematically sound setup. A 4 French vascular sheath safely accepts a 4 French recurved catheter. Inside that catheter, a 0.035-inch guide wire is used to navigate the sharp downward turn and hook securely into the target vessel. Because the SMA handles a large volume of blood, it requires a rapid pump injection. To prevent violent backward recoil during the pump run, the operator must select a side plus end hole morphology. With the correct tool in place, the operator can safely push contrast at a rate of 5 to 7 milliliters per second, resulting in complete, high-pressure vessel opacification without displacing the tip. Safe angiography is never the result of trial and error. It is the deliberate, rigorous execution of a mental model that dictates precise rules for physical sizing, vascular geometry, and fluid dynamics. We can now synthesize these isolated rules by executing a high-flow angiogram of the superior mesenteric artery. Reaching the obtuse angle of the SMA requires a mathematically sound setup. A 4 French vascular sheath safely accepts a 4 French recurve catheter. Inside that catheter, a 0.035-inch guide wire is used to navigate the sharp downward turn and hook securely into the target vessel. Because the SMA handles a large volume of blood, it requires a rapid pump injection. To prevent violent backward recoil during the pump run, the operator must select a side plus end hole morphology. With the correct tool in place, the operator can safely push contrast at a rate of 5 to 7 milliliters per second, resulting in complete, high-pressure vessel opacification without displacing the tip. Safe angiography is never the result of trial and error. It is the deliberate, rigorous execution of a mental model that dictates precise rules for physical sizing, vascular geometry, and fluid dynamics.